In this video today, we're going to talk about why fibromyalgia is a diagnosis most doctors hate to make. We're going to explain this in depth and detail and also talk about how this impacts patients. If we haven't met, I'm Dr. Orlando Landrum. I'm a physician that helps patients understand what are their options for being able to deal with pain, whether it's physical or whether it's mental, and how to be able to punch pain in the face and get back to leading the life they deserve. Let me just be straightforward. As a physician, there are times when I've had my doubts about fibromyalgia's legitimacy. And fortunately, I've been able to kind of get insight, get understanding, and really be able to get further knowledge about the disease to know that it has legitimacy and that there's ways to be able to evaluate and assess it. I think many physicians have some degree of biases that are in place. Not all, but many do. And we're going to talk about what are some of the reasons and rationales that might be the case and what can you do about it, more importantly, as a patient, to figure out how you can be able to get care and care that works. So normally when we talk about fibromyalgia, traditionally it's been this kind of disease state that has focused on these tender points that have been present. So the patient is palpated by their provider, they're evaluated, and various different points are pushed and pressed and tried to be able to decipher, is this an area that has some degree of pain? The classic chart looks something like this. So you have these different points that are present and you have areas that are in place. However, fibromyalgia diagnosis has evolved consistently and rapidly to not be dependent upon just these points. And I think if you ask the average practitioner, they may think that, hey, this is still the way to do it. Well, now there's a new way to be able to kind of evaluate it. There's a study that was put forth by one paper that's called, that was in an area called the MIGHTY, that looked at fibromyalgia diagnostic tests. And I would say, as you can see in that purple component, the vast majority of people and physicians have related to physical pain and trigger points, meaning points underneath pressure that show and demonstrate that there's pain. I would gather most people don't know that there are blood tests that can be able to assess fibromyalgia. We're going to talk a little bit about that and whether it's useful or not. But there are other ways to be able to diagnose fibromyalgia as well. And that includes radiologic evaluation as well as imaging, in addition to potentially also getting things like spinal taps and such. So all those things are like, wow, didn't even know that existed, right? Well, one of the things can be able to look at kind of clinical symptomatology. And clinical symptomatology has a number of different things that kind of puts the pieces together to help patients have an idea about whether this might be a fit and helps clinicians to identify if this might be a fit. So kind of starting from the 12 o'clock position on this circle and going around, one is, does this person have widespread pain? Is there fatigue, which is actually interrupting daily activities? Are there hypersensitivities to activities? Has this been going on for a period of time? Are there ineffective treatments that have been in place? And are there impacts like feeling overwhelmed or poor concentration? So those things could potentially give us clues to fibromyalgia as being a possible diagnosis. So for those of you who join us with some degree of regularity, you know what we really like to do is to be able to kind of reference the literature. So we're going to really rely upon a couple different papers and statements that have kind of evaluated things. So one is this paper that looks like the diagnosis of fibromyalgia. And the second is kind of a commentary, but it's facts and myths pertaining to fibromyalgia. So that way you can be able to reference it and see it for yourself. One of the most interesting statistics that I've seen produced from the aspect of the MIGHTY is that the average number of years to get a fibromyalgia diagnosis is 7 years. And the average number of doctors to be able to see a patient to get a diagnosis is about 5. That to me is quite a bit and is onerous and is challenging and is frustrating. And that's why you see a number of the fibromyalgia support groups that really talk about many of the challenges that patients face with this diagnosis. And let's talk a little bit about the myths and also what are some of the stigma and issues that are associated with fibromyalgia so we can have an honest conversation and then talk about what are some of the things that we might be able to do in order to be able to treat it accordingly. So fibromyalgia historically has been controversial, seriously, in a bitter fashion and way. By the way, those of you who are joining us live, put in your comments and we'll see if we can be able to kind of be able to put those forth and respond to them accordingly. And there's been just battles in the medical literature about the legitimacy and whether it's appropriate and how to be able to kind of own it or make decisions about how to be able to treat it. Right. And this has been ongoing for decades, not just in academic circles, but in clinical circles as well. So the historic myth is that it's only middle-aged women and that it's present in a certain select group and the preponderance is of a certain gender to male to ratio. So what we see is that actually it is present throughout the general population. And although there is a degree of preponderance for women between the ages of 40 and 60, there are other individuals who have this not based on age and not based off of gender. And most of this has been looked at with that tender point criteria, which quite frankly is a bit antiquated. And there are other ways to do this, which we're going to talk about in terms of diagnosis. Some of the other things is there's many docs who will say fibromyalgia doesn't exist. And that if a patient hasn't been diagnosed by a pain specialist or rheumatologist, that there's really no legitimacy that's in place. Other things are, if you can see in that third line, the preponderance of the biomedical model in medical practice. And so the biomedical model has been prevalent probably for the last 15 to 20 years, which basically says that we need to be able to attribute a disease based off of pathogens, a disorder, and really it's quite useful to be able to assess it. How can you be able to functionally assess or quantify it, if you would? So fibromyalgia has been classified historically as a pain disease, which really hasn't necessarily done it any favors in some ways, but there's been this categorization of it being a chronic primary pain. Traditionally, it's persisting or recurrent for longer than 3 months, and there may be emotional distress that's associated with it, and certainly functional disability. So when we talk about that, yes, one of the comments that one of our patients who's joined us has said is that people have said it's all in their head, which is frustrating as heck, and just really problematic. And that's what we're trying to be able to kind of give you ideas and assessments of why docs think certain things and how to be able to kind of dispel that and how it's not your fault. All right. So going forward, is we talked about this kind of characterization as a pain disease, but it's probably a little bit broader than that. So sometimes it's been listed as kind of put in the commentary that it's a mass depression. And there is certainly depressive disorders that are present with patients that have fibromyalgia, but it's not just a brain disease that it's in someone's head and they have somatoform, meaning that you are having these thoughts that it's a problem and issue when it's really not. The other is that it's a brain disease. And there's some element of this, but not meaning so that it's all in your head, but more so is dealing with the brain pathways. And we've been talking about this over a number of different weeks, but one of the corollaries or contexts is that maybe there's something that's called central sensitization, which is kind of this wind-up phenomena of making pain potentially worse. And it's really significant to brain regions and how they talk to one another. And what you can see is that within this case, there's a decreased connectivity, which sometimes when you can be able to improve that connectivity, things can get better, right? And so that decreased connectivity is present in particular in those areas that stop pain, that can calm pain down. So what I mean, let me kind of explain this in English. I was actually just talking to a patient maybe about a half hour or so ago, and they're like, you're using fancy words, but I don't understand it. And I'm like, okay, well, that being the case, then interrupt me. So in this context, I'm going to interrupt myself. So when we talk about connectivity, what we're talking about is if you have a discrete area of pain, or a part of the brain over here, and you have another part of the brain over here, what we're looking at is how those two talk to one another. There's certain pathways that are actually instrumental in basically decreasing pain. People have heard about endogenous opioids, meaning like you get a runner's high and you don't feel any type of pain that might be going on in your legs. The same type of thing where you have pathways that are meant to decrease our pain. Well, those pathways in fibromyalgia are believed to not be as prevalent, to not be as strong. So possibly by increasing the strength of connection and the pathways that help decrease pain, we may be able to decrease the presentation of fibromyalgia. So Sorry about that. Let's kind of skip back. So that brain disease component also is associated with neurotransmitters as well. And we've talked about that and whether there's ways to be able to improve that neurotransmitter presence and function. And then other thoughts have been that it's a small fiber neuropathy, meaning that there are nerves that are present that are not functioning quite the way that we'd kind of expect. And so it's resulted in this chronic pain condition. Well, this is one of the pieces that I would say is probably really instrumental to diagnosis not being appropriate. And you can see it highlighted in yellow. Over the past 3 decades, it is no longer accepted as reliable clinical finding that dealing with a tender point examination is the only way to be able to do diagnostic criteria. As a matter of fact, there's a revised way to be able to assess how to be able to deal with fibromyalgia, or at least evaluate, may someone have fibromyalgia. So the basic way is reliant upon 3 different points. One is their widespread pain index and symptom severity scale, which will explain what those things are. 2 is, are there generalized pain in at least 4 or 5 regions of the body, which is different than the aspect of these 12 different tender points that are present. And then, has this been going on for at least 3 months? So let's talk about this, right? So what we see is when we look at this, the American College of Rheumatology basically said, as mentioned, generalized pain in 4 or 5 regions. We'll kind of show a picture of that in just a second or so. How the symptoms have been going on for 3 months. And then a widespread pain index score is greater than 7 and is the symptom severity score greater than or equal to 5. A diagnosis of fibromyalgia is valid irrespective of other diagnoses. And a diagnosis of fibromyalgia does not exclude the presence of other clinically important illnesses. So let's look at these regions, which are a little bit different. So the regions, as you can kind of see, are a whole host of different parts of the body where you can see these colorations that are in place. And so what you're looking for isn't now these discrete points, but do you have regions that kind of support this in the areas as mentioned before of at least 4 or 5 regions? And that is one of the starting points. The other portion is this widespread pain index. And so it's a questionnaire, and this questionnaire is able to kind of evaluate where's the pain and what's the context in which that pain exists. Secondarily, you can have, in addition to that, something that's called the symptom severity score. And that symptom severity score has 2 parts. The first part is rating the severity of the pain, fatigue, and potentially cognitive challenges. And then the other aspect is by identifying how much it disrupts function. And being able to, how much it disrupts the patient's life, right? So those things are ways to be able to kind of have the starting point of assessing, is fibromyalgia potential utilization? However, there's some other newer ways, which I'm not so sure most people know about. And one of those is by doing an actual blood test. So there's a blood test that's called an FMA test, which is a diagnostic test for fibromyalgia. And that is for people that have an uncertain diagnosis and have at least 4 of the typical symptoms, right? The cost is pretty expensive, but the challenge and the issue is that most insurances, many insurances will actually potentially cover it. So it may be useful. The sensitivity is pretty decent, meaning how easy is it to be able to tell what's going on. The specificity is also pretty good, meaning it doesn't mistake other potential issues as other potential diseases as a problem. So in summary, that test is covered by many insurances. It helps some patients be able to differentiate, is it fibromyalgia? Is it rheumatoid arthritis? Is it lupus? And there's some ability to be able to kind of utilize that. There's some other blood tests that are different, which are RNA blood tests. And they have been out for a few years. The most frequent of which is something that's produced by a company called Equity, I believe it is, that uses RNA gene expression, which is a little bit different than the FMA test. And that RNA test is able to predict the risk, and it's able to kind of evaluate to a faster and even more effective treatment. So there's a number of different ways to be able to assess, is fibromyalgia potential for a patient? As we mentioned, the old 12 tender points is not just it. It's how it impacts the patient's life, how it's going on with the aspect of the functionality in 4 different body areas, and really whether it makes a potential difference to that person. So again, is it widespread pain in multiple regions of the body? Is it intrusive fatigue? Is it hypersensitivity? And has this been going on for at least 3 months or so? So that's fibromyalgia in a nutshell, with a more evaluative way of assessing, other than us just saying, oh, well, automatically it's these tender points, right? And that's what's going on. Now, it's now kind of looking at a more comprehensive assessment of widespread pain and how it's affecting the person as a whole in order to be able to identify how to make an impact. For those of you who kind of missed the first portion, the things that we mentioned is that many patients take 7 years before they get an official diagnosis, and they have 5 doctors they have to go through before they can be able to get some degree of diagnosis. So we know that treatment can traditionally rely upon modalities like physical therapy, as this algorithm sort of shows. But it also can be able to be looking at mood as well as sleep and how to be able to improve those things to have some degree of improved functionality and reduction in pain. And sometimes you can use medications to be able to make this better. One of the talks that we're going to actually be putting out is a way to be able to treat it non-invasively that's shown pretty good success. And that's going to be a talk that looks at treatment that is a non-invasive methodology. For those of you who are close to us, if you're interested in pursuing something like that, you may want to look at the following as a potential option to say, hey, maybe we can be a potential candidate for that non-invasive treatment. And if so, you really want to kind of take a look and evaluate, give us a ring, and maybe we can be able to help you out. As always, one of the things we want to do is to help patients figure out how to be able to know their options, how to be able to overcome stigma that sometimes is present in implicit bias, and help you know how to be able to take control of your life, be able to be an advocate for yourself or those that you care about, and how to punch pain in the face, get back to leading the life that you deserve. As always, thank you so much and have a great day.